Hello, welcome to Leukemia and Blood Cancer New Zealand's first webinar for 2022. We are delighted to welcome back Dr. Rob Weinkove, who is presenting today on COVID-19 and haematology patients, protecting yourself in 2022. Dr. Weinkove practices as a consultant haematologist at Te Reirena Ora Blood and Cancer Centre at Wellington Hospital and at Keneparu Hospital, Porora. Rob is clinical lead for CLL and hemato-oncology supportive care in Wellington. He holds a joint role as clinical director at the Mulligan Institute of Medical Research. After studying medicine at the University of Cambridge and King's College London, Rob trained in haematology in London and in Hanover, Germany. He has a PhD from the University of Otago in the field of immunology and CLL. Rob is an active member of the Australasian Leukemia and Lymphoma Group. He contributes to a cooperative group and to commercial clinical trials. He is a principal investigator of an investigator-initiated third-generation CARS T-cell trial. Many thanks for coming in today, Rob, and I will hand over to you.
Yeah, look, thank you very much. I hope you can all hear me okay, and thanks for joining today. And thanks to LBC for organising this. So it feels timely, but I guess it always feels timely. We've been dealing with this SARS-CoV-2 virus or COVID-19 for a couple of years now, and we're at a position at the moment where we're just on the cusp of seeing community transmission of Omicron, and that's going to have implications for all of us. In the hospital and outside the hospital, and it does have a significant impact on some of you as blood cancer patients or people who are looking after family or whānau with blood cancers. So I'm going to speak a bit to the Omicron variant today. I'm going to talk a bit about how this virus is transmitted and what that means for us all in the hospital, but also for you as patients. I'll talk a little bit to the groups of patients that at least I perceive as being at particularly high risk, and then go through some things that you can perhaps do to at least try and reduce that risk. I'll also speak to COVID-19 treatments, those that are available and those that may be coming in the near future, and the impact they have. And then I'll just sort of summarize those things together. So to do this, I'm going to share some slides. You're free to use the Q&A. There's a Q&A box on your Zoom, and I'll run through some Q&As afterwards and address some direct queries. So I'm just going to move on to a shared screen and run through a slide with you hopefully now. Now, hang on, I'm just going to see if I can do that again, just as the, there we go, that one. Good, so hopefully you can see a slide. So we've run through a few different variants of this virus. It's all the same intrinsic virus, and what's been happening is it's been mutating to adapt to spread more rapidly, and also potentially in the future to adapt to become relatively more resistant to the vaccines that we currently have. And that's not really unexpected. That's what other viruses do. That's what influenza does. That's what other seasonal viruses do. And so we are not hugely surprised to see that as an issue. So I'm going to start with the bad news. So what's the bad news when it comes to dealing with this particular variant? And the major news there is that Omicron is very, very transmissible. It's much more transmissible even than the Delta variant, and that was more transmissible in turn than the very first version of this virus that emerged just over 2 years ago. And it's roughly as transmissible as measles, which is one of the most transmissible viruses that we know. And I'll talk a little bit about that and how it's spread later on. It also spreads very quickly, and what we can expect to see is cases rising very rapidly, particularly from next week once the schools go back, because there'll be a lot of spread arising between families from school environments. And the experience from overseas is that it can double in numbers every few days. So it might feel like things are taking off slowly, but then the cases start to rise very rapidly. There is a lower degree of protection against what we call symptomatic infection, by which we mean getting symptoms because of this particular virus variant, than there was against Delta or the original version. There is still some protection, which I'll talk about in a moment, and there does appear to be some protection against the most severe manifestations. So the vaccine is still useful, but the degree of protection, as I'll show you in a moment, is lower. And Omicron is resistant to some of the antibody-based treatments for COVID-19. But there is some good news as well. The first thing is, it wasn't entirely clear at the end of last year, but it is now very clear now that Omicron is less severe than the Delta variant that preceded it. And in fact, there's also Delta cases in New Zealand at the moment, so we still have to be aware that that's still there. It's in terms of when it arises in non-blood cancer patients, there's about a quarter of the chance of ending up in hospital if you get the Omicron variant of this COVID-19 than there was compared to the Delta variant. And it's roughly similar reduction in the chance of getting really severely ill. So a third to a quarter of the chance of the Delta variant. So that's good. Also, for those who do end up in hospital, there's less chance of being in hospital for as long, and there's less chance of needing oxygen. And those are important things, both for us all as individuals, but also for the ability of the healthcare system to cope, particularly because this can spread so much faster. So the peak of cases or peak of people infected at any one time could be higher than it was with prior variants. Even though there's reduced protection from the current vaccines that we have, the vaccine that we have is still effective, and I'll show you the data on that. However, it does very much appear that a booster dose is necessary, and that's why you'll have seen some clamour in the media really imploring people to go ahead and get their booster doses when they become eligible for them. And although some treatments don't work well against the Omicron variants, other treatments do seem to work just as well as they did against other variants. So the vaccine that we're using in this country predominantly is a vaccine from Pfizer. Hopefully most or nearly all of you have received at least 2 or 3 doses. And this vaccine was designed against the original SARS-CoV-2 virus, and it was really very, very effective and astonishingly effective. I don't think anyone expected it to be as effective as it was. It had some reduced effectiveness against the Delta variant, which was restored by giving a 3rd dose or a booster dose. And however, 2 doses of the Pfizer vaccine have really quite poor protection against getting a symptomatic infection with this Omicron variant. And it's just that the antibody levels aren't quite high enough. The antibodies that are generated by this Pfizer vaccine aren't as perfectly matched to this version of the virus. So while we have other vaccines that are currently in development, Pfizer's already testing versions directed specifically against Omicron, and I'd be confident that they work. We're not likely to have those until at least the middle of the year. So we are stuck with the vaccine that we've got. It does work, however, if you give a booster dose where there's 65% effectiveness against a symptomatic infection. And that's important. And that's part of the reason why you're seeing the government implore people to get the booster, because their modeling of the number of patients needing hospital care for COVID shows that people getting a booster dose makes a big difference to the number of people needing to come in to the hospital wards with COVID-19, or also getting very sick and needing intensive care. And that has a big knock-on impact to our ability to deliver all the rest of the hospital and healthcare services. So very important that everybody gets their booster doses as soon as eligible. I just want to speak to a moment about which groups of haematology patients are most at risk of COVID-19. And this is actually surprisingly difficult information to interpret and find. And the reason for that is there are lots and lots of different blood cancers. There are lots and lots of different blood cancer treatments. The diagnosis that some of you may have interacts with other risk factors like age or other illnesses people may or may not have. And also that most of the studies looking at this have sort of been surveys of haematology services, and those tend to be biased because the haematology services often only become aware of the patients who are most sick already. So they often give an overestimate of how bad things are. But what has come about from the studies over the last couple of years, and bear in mind, most of these data are from the alpha, beta, or delta variants, not from Omicron, is that there are a number of risk factors where the risk does seem to be particularly high, and high even in comparison with, say, solid cancers. And those seem to be people who are currently having treatment, especially intensive treatments for AML, or who have recently been treated for those conditions, and people who are currently getting treatment for myelodysplasia. So I'm talking about chemotherapy, either intensive chemotherapy or drugs like azacitidine or venetoclax. Those seem to be significant risk factors for getting very sick with COVID-19. Higher risk myelofibrosis that people are on treatment for, so people on medicines like ruxolitinib, for higher risk myelofibrosis do appear to have a higher risk of bad outcomes. Same with people currently getting treatments for non-Hodgkin lymphoma. And I'm going to talk about some things that you can perhaps do to mitigate those risks. Myeloma, and that's throughout the treatment course, not so much as I'll talk about in a moment, asymptomatic or myeloma before any treatment, and also CLL and a rarer related condition called hairy cell leukemia. And this includes people getting outpatient-based treatments, so people getting outpatient chemotherapy for myeloma, people taking BTK inhibitors or venetoclax, or outpatient-based chemotherapies for CLL. These do appear to be risk factors compared to people who don't have blood cancers of getting more unwell if you develop COVID-19 and perhaps even needing intensive types of treatment or oxygen. Acute lymphoblastic leukemia is a risk factor. It looks to be a little bit of a lower risk factor, but this is difficult to interpret because a lot of people with ALL are younger and there's more children in that group. So it's difficult to know whether that's because of the age profile of the people with ALL or whether that's because of differences in the way it's treated. But these are nonetheless all risks. There's certainly a high risk if you've had a bone marrow transplant, especially if you've had it very recently. So if you're currently undergoing a bone marrow transplant, whether autologous or allogeneic, or you've had one in the last 3 months, that does seem to be a risk factor for severe COVID-19. And again, I'll talk about ways that you might be able to try and mitigate that risk. The other group would be people who've had an allogeneic transplant and it's more than 3 months ago, but they have something called graft versus host disease and are still taking immune suppression medicines like cyclosporin. That does seem to be a risk factor. And in addition to those, other factors might add to that risk beyond this. And this has come up in what we call multivariate analyses. It's a way of trying to disentangle all these different risk factors. But it does add to that further if you're older in age, especially those 70 age plus. And of course, that's a big proportion, and in some cases, the majority of people with these particular blood cancers. So that's really important to bear in mind. If you've got kidney, liver, or heart failure, that's a risk factor. And if you've got a history of smoking-related lung disease, that's a risk factor too. So these, I'd say that people in that top group, especially if they've got some of the factors at the bottom there, are in really quite a high risk group. And I think if you're in that group, as I'll say a bit later, I think you really need to be taking precautions that might go above and beyond what the government is recommending for the rest of the population at large. In contrast, there are some people with blood cancers for whom the risk doesn't seem to be hugely higher. And that includes people who have had a treatment, say if you've had treatment for AML that is hoped to lead to cure, and that was more than a year ago. Similarly, if you've had a treatment for a lymphoma and you're in a complete remission and the treatment was more than a year ago, that risk seems to be rather lower at that point. Perhaps the one exception is those of you who've had so-called purine analogues like fludarabine or cladribine or bendamustine, where there is some degree of immune suppression that can take a couple of years to resolve. If you're just under follow-up for early but not treated myelodysplasia or CLL or myeloma, so if you've got very early myelodysplasia and just being monitored occasionally for your blood counts but you're not in any treatment for it, if you've got early CLL and you're under hospital or primary care follow-up, but you haven't had treatment yet, or if you've got early, or say asymptomatic myeloma, that risk doesn't appear to be much higher. Now, it may still be increased somewhat, but it doesn't seem to be in this very high risk group. There's some people with so-called myeloproliferative disorders, polycythemia vera and essential thrombocythemia. The risk probably isn't huge with these conditions. I'll just say that for ET or essential thrombocythemia, there have been some early studies that suggested that was a high risk, but that hasn't borne out in later waves of COVID. And it may be because in those very first waves of COVID, which if you remember, happened before there was any vaccination. It wasn't routine to give sick patients with COVID blood thinners, whereas now it is routine. If you get admitted with COVID-19, you usually go on blood thinners during your admission. And so that early bad outcome for patients with essential thrombocythemia may have been due to blood clots before we were routinely giving blood thinners to patients in hospital with COVID-19. So at the moment, that risk doesn't seem to be enormously high. It's not to say there's no additional risk, but it doesn't seem to be enormous. And the other group that's very relevant is there'll be a lot of people with chronic myeloid leukemia who are taking treatment for this, such as imatinib or dasatinib. At least as far as we know so far, the risk of that does not appear to be huge and may not be much more than the general population. Again, the weakness of this study that I've got most of this data from, but also the other ones, is that they're sort of opportunistic studies, and therefore they're not entire population based. And so these are estimates rather than absolute values. It's not like they swabbed every patient every week to see if they had COVID or not. And so they may have overestimated poor outcomes because people with mildly symptomatic COVID didn't get recognized in those studies. But that's the way I would perceive this. And it's not to say that if you're in that green lower risk group that you needn't do anything, you still need to take care, but it's the group in the sort of orange to the left of this figure that I think need to be particularly careful, and I'll talk to that in a moment. So what can you do? Well, the first and most important thing is vaccines. Even though the vaccine efficacy against Omicron is reduced, it does remain highly active, and vaccines are a very, very safe intervention to give. They're safe for pretty much all patients with blood cancers. Only real exception would be if you'd had a severe allergic reaction to pegylated asparagine for AML, for acute lymphoblastic leukemia, and that would be very rare. So for most people, there are 3 funded vaccine doses: dose 1, 3 weeks later, dose 2, and then 4 months later than that, a booster dose. Now, there's a bit of questions that sometimes come along about whether to try and mix and match the vaccines. The AstraZeneca vaccine is now available in this country for people who want to get that instead. The mix and matching I do not recommend unless you've got AstraZeneca first. So if you've got the Pfizer vaccine first and you haven't had severe side effects from it, stick with that vaccine. So basically the benefit of switching type of vaccine is only really for those who got a weaker type of vaccine like the AstraZeneca one and then switch to Pfizer. The benefit is not in the other way around. So if you'd already had Pfizer, I'd stick with that one in this country. It's actually relatively simple here because we haven't had that many vaccines available. Now, for people who are what we call severely immunocompromised, by which I mean that they're, well, I've got the definition below and I'll talk to that in a moment. There is the potential option to get a 3rd primary vaccine dose. And that's because in people whose immune system is weakened, there's evidence that a 3rd vaccine dose can bring the level of antibodies up to similar to that, for some people, similar to that people who aren't immune suppressed have. And the strange way that this has been done here is that 3rd primary dose is an extra dose above and beyond anyone else. And that 3rd primary dose is given 8 weeks after dose 2. And it requires a prescription and it requires a consent form. And it's been, those of you who've done this may have found it's been quite an awkward process. We found it awkward as clinicians to administer this process. The 3rd primary dose is 8 weeks after dose 2, and then you can still have a booster dose. So the idea is that people who are severely immunocompromised can get a total of 4 vaccine doses, 3 initial ones plus a booster. Those criteria cover most of the people I think are at high risk, so including people who with leukemia or aggressive lymphoma that are under treatment or within 12 months of achieving a cure, people with all those indolent lymphomas and so on, which are listed there, people who've had a recent bone marrow transplant or who are still on immune suppression after a transplant, and importantly, people on chemotherapy or immunosuppression, and that definition is quite broad. Now, different clinicians have taken different attitudes to what constitutes that. Because there's some evidence that people taking hydroxycarbamide, and some of you with polycythemia vera or ET may be taking that medicine, have a slightly lower antibody response to vaccination than those that aren't. I've been signing those forms off for people taking hydroxycarbamide for a 3rd primary dose as well. And I think that fits the criteria. There's a bit of discussion. I know some of my colleagues in Australia recommend that as well, but you may find different haematologists disagree on that point. And there's some guidelines. A lot of this guidance is available online. One thing that's relatively new, and this came about a couple of weeks before Christmas, so it might have flown under the radar when people were looking at COVID cases then and getting ready for the holidays, is that if you started your COVID-19 vaccines and you then had a bone marrow transplant, and there will now be some people in that situation, you can then get a full revaccination right from scratch. And that the reason for that is that autologous and allogeneic bone marrow transplants can both sort of get rid of your pre-existing immune responses. This is, I'd say that because it was kind of announced just before Christmas and sort of not widely publicized, some people may not be aware of this. So if you started your initial COVID vaccines and you've since had a bone marrow transplant, I suggest that you contact your bone marrow transplant coordinator or BMT nurse. You're eligible for a full course of revaccination, and those extra doses have to be done by prescription and need a consent form. So it's a little bit awkward, but the number of people in this group will be quite small. If you think about it, that means that, in fact, for this group, people can get up to 7 doses of this COVID vaccine, 3 initial ones, then a bone marrow transplant, then the 3 revaccination ones, then the booster. So look, there is the option to revaccination after transplantation for some patients. So you've also seen this week, or the last couple of weeks around the Omicron, some discussion about masks and about the need for good masks. And I just want to speak for a moment on that, because I think that is something where you may be able to do something to protect yourself, particularly if you're in those high risk groups. And I think this is where I think, you know, 1 or 2 errors were made early on in the pandemic. I'm not talking about this country specifically, I'm talking about globally. And one of those errors was right from the World Health Organization to state categorically early on that COVID-19 wasn't spread through the air, when in fact, clearly it was and is. So COVID-19 in generally is airborne, as you might expect for a respiratory or lung spread virus. And what is generally meant by airborne is when it goes into what we call fine aerosols that can then float throughout the air. So it's not like the virus actually has wings, it can't float. But the virus, and particularly the more infectious versions of it, like Delta and Omicron, can survive in very tiny aerosol particles. So all the time when we're talking or breathing or singing or shouting or coughing, of course, or sneezing, we're all producing tiny little invisible liquid particles, and they form a so-called aerosol that then sort of floats in the air. And the important thing about these aerosols, unlike the big droplets that you might see if you sneeze near a mirror, you'll see those splatter all over the place. Those fall quite quickly to the floor. These are very, very tiny particles, less than 5 microns, and they can actually hang around floating in the air. And the important thing about those tiny particles is they can hang around for hours. And the reason that that's important is that if you're in an enclosed environment like a room, you're not just potentially sharing respiratory viruses with the person who's in that room with you now, but also potentially the people who were in that room an hour ago or 2 hours ago, even in some circumstances, particularly if that room isn't well ventilated, as I'll speak to in a moment. Those aerosol-borne particles can also pass through ventilation systems. And of course, we now know that those cases of COVID-19 early on that were spreading through cruise ships, they probably were through the ventilation systems. It was kind of denied at the time, but that probably was the way it was spreading between one room and the next. So COVID in general, and Omicron in particular, very much is airborne. And that's why the masks are so important. And that's why there's a renewed emphasis now on masks. So this is just an illustration and that shows why universal mask wearing is so important. So the masks aren't just there to protect the person who's wearing them. They're also there so that if one of us has COVID-19 but doesn't have any symptoms, and many people will have COVID-19 and not really know about it. They might just have a very mild runny nose or a tickly throat or nothing at all. They might be shedding the virus without knowing. By everybody wearing a mask, the people who have the infection push out fewer particles, as well as the person on the potential receiving end breathing fewer particles in. So the universal mask use is very important. And that's why that's part of government policy and why it's been policy in our clinics for quite a while now. And sorry that this is a slightly, very complicated slide, but I'm going to point out why this is important. And this relates to some stories you might have seen in the media. So not all masks are made equal. The weakest type of mask is a loosely fitting cloth mask or a bandana. They really let a lot of, all they really do is stop those very big droplets from sneezing out. They don't do very much to filter out those very fine aerosol-like particles. Surgical masks, which are most widely used, I've got one here, are quite good, but they're not really designed for airborne viruses. They're designed to stop surgeons sneezing over a patient having an operation, and they're designed to stop splashes getting into your mouth. So they're very good for those big droplets, but again, they're not brilliant for those fine aerosols. And although they filter quite well, the reason is the seal is often not very good. So when you're breathing in and out with one of these surgical masks, the air will often seep around the edges, and that in fact makes it easier to breathe with them. Now, the reason this is important is there are some better types of masks, sometimes called respirators, and I'll talk about those types in a moment. But this is a study from a well-known journal. It's actually a study based more on physics and modeling and some measurements rather than direct infections. But the important thing is that they modeled some situations of where you've got somebody infected with COVID-19 and somebody who's susceptible to getting COVID-19. And in this particular model they were using, and again, this is just a demonstrative percentage, 10% of the susceptible people picked up the airborne infection when both the infected person and the susceptible person were both wearing a straightforward surgical mask like this. In contrast, if the susceptible person, even if just the susceptible person, i.e. you, the people with blood cancer, wears a proper respirator, and I'll talk about those in a moment, the risk of inhaling a particle containing the virus and therefore getting the infection appeared to be much lower, about a 5-fold reduction. And that's shown at that lower part 1.5. Obviously, the best is if everybody's wearing those respirators, but you can't change other people's behavior. However, you can consider it back to change your own behavior, and this is where this could become important. So what do we mean by a respirator? I've put some pictures on the bottom of this slide. You can see a few different examples. It's certainly confusing. I found it confusing at first, and that's because there's several different standards or certifications for these respirators, and the standards are P2 or N95 or FFP2 or KN95. Those 4 standards are all, to all intents and purposes, pretty much the same. There are small differences between those standards in pressure gradients and the way they're tested. But in essence, those 4 respirator standards are very, very, very similar. And any one of those is a big improvement over a surgical mask. So if you can, and they're getting more hard to get hold of at the moment, I appreciate that, but if you can get hold of some of those to wear when you're in shared indoor environments, aerosol risk is much lower when you're outdoors, as the wind sort of ventilates those aerosols away and they don't hang around. So less worried about being outdoors. But in those shared indoor environments, if you're having to go on a bus, if you're, well, maybe you shouldn't be going to the cinema, but if you're in an enclosed environment like the cinema, this is where you might want to be wearing a really good respirator. And unfortunately, they are just a little bit more uncomfortable to wear. They're designed to give a tighter fit. They do get hot in hot weather and uncomfortable, but they do afford a better degree of protection against aerosol-borne viruses, including COVID-19. If you have the option, if you're looking at them, pick a mask with a head strap. That is one that goes round the back of your head, not one just with loops that go over your ear. And that's because a number of studies have shown that when you have the respirators with ear loops, like the one in the middle of those, the 3 at the bottom, there's usually a gap around the cheeks where the air gets in and out. And if it's just ear loops, sometimes it's not much better than a surgical mask. So if you can get one with head straps that go around the back. Some of these masks have valves in to make it easier to breathe out. I would say that's a slightly antisocial thing to do, and that's because the breathing out then doesn't go through any filtration at all. So if you've got if you see someone with one of those masks with an outgoing valve, all of the air that they're breathing out goes into the environment without being filtered whatsoever. So it's a bit antisocial to have a valved mask like that, in my view. I just think it's really important that if you are going to get good masks, that you take the time to actually go on YouTube or look online to learn how to put them on properly and how to fit them properly. So pretty much universally, any respirators meeting this standard will have a wire thing that goes across the bridge of your nose that has to be firm. They have to be sealed around here. You can go online, look on YouTube, there's a story there on stuff I've put on the screen. Look at how to put them on, so you work out how to put them on and take them off properly so that they actually do what they're meant to do. Otherwise, it can be a little bit pointless. So I do suggest, particularly those of you in those high-risk groups, that you try and get hold of some of these respirators and to use when you're out in shared indoor environments and you're at risk of inhaling the COVID-19 virus. This is just a demonstration. This is from the Center for Disease Control, CDC, in the United States, about the impact of ventilation. So you may not be able to do anything about this, but in some circumstances, for example, in certain workplaces, you might have the option of doing things like opening the window, depending on what role you're in. Maybe you have the option of persuading your employer to get a HEPA filter. But certainly those aerosols that hang around clear a lot faster if the room is well ventilated. And that's why there's a lot of recommendation from overseas about opening windows, opening doors. In the UK, all through the winter, a lot of schools kept their windows open and the kids were sitting indoors. I know my nieces in the UK were sitting indoors with their jackets on because all the windows and doors were kept open when they're in their classroom in the run-up to Christmas this year there. Special filters, HEPA filters, do an even better job. They're used, for example, in MIQ situations and also in hospitals, but they have a significant cost. But even just opening windows and doors can help, and there may be some situations where you can do that to improve the ventilation. So I want to speak to a moment to COVID-19 treatments, and I'm going to show you a slightly complicated slide. And the reason I put this up was firstly to get an update myself, but also because it's something that many of you will be conscious of. Well, what happens if I do get COVID-19? Can you treat me? I want you not to focus so much on the individual drugs here, but the first thing I want to point out is that there are some treatments highlighted here in green that are available or currently in New Zealand. All those treatments in green are here to some extent or another. The issue is that most of them are only really for use once people actually get quite sick with COVID and need to be in hospital and are on oxygen. So drugs like tocilizumab, baricitinib and remdesivir at the moment are only used for people in hospital. The other thing is that a lot of these medicines have quite limited availability. So although they are here, the stocks are quite low, so that the criteria for getting them are quite stringent. So it's not that you or I could expect to get these medicines if we get COVID. There'll be stringent criteria. These are changing all the time and are likely to continue to change as Omicron comes along as more data can become available. And they will be contingent upon national supply of the drugs as well as everything else. Most of these drugs are only, I would say, moderately effective, by which I mean, say, a 30% reduction in poor outcomes, such as getting more sick. Remdesivir does appear to be very effective if it's used at the right time point, but supply of that is really quite limited. And I think the issue that we're facing in New Zealand and worldwide is that there's a global demand for these medicines that is enormous at the moment. So every country in the world is trying to get these medicines, and some countries that manufacture these medicines are declining to allow them to be exported. And we don't manufacture any of these in this country. So that's what one of the limits is. We've got two drugs that have been announced or that we have a reasonably firm date on when they're arriving. One of them is an antibody treatment called Ronapreve. Unfortunately, that doesn't work against Omicron, and that's a real shame. It does work against Delta, and there is some Delta around in this country, but it doesn't work against the Omicron variant, which is very disappointing. And this is why I'm sort of pushing up this notion of the masks and ventilation, and possibly the idea that some of you may be well advised to minimize social contact as Omicron becomes more and more widespread. And that's because there are some highly effective medicines that are known to be very, very effective against Omicron, but which are not here yet. So we do have, and this is from the public media, that there's an announcement in, I think it was in Radio New Zealand, that the government expects to get Paxlovid in April. This is a highly effective tablet antiviral that works very well against Omicron. And if you're in that group where you're very, very immune suppressed and very much at risk, it's worth seriously considering trying to push back your exposure to this virus until that drug is in the country and available. I would just point out, by the way, on this chart, I've put whether the drugs are MedSafe approved. If it's not approved, that's not necessarily a barrier to its use. We are still allowed to prescribe unregistered medicines. There's just it's a bit more hassle for us at the hospital side. But for example, some patients are getting remdesivir, which isn't approved, and there'll be some patients around the country getting that right now in hospitals. I hear and I understand that the government and Pharmac are working very hard to get some of these medicines in. Of course, they're facing demand from the rest of the world, including much bigger countries like the United States. And I think it's a consideration, if you're a group at a very high risk, to consider shielding yourself and minimizing your risk of picking up COVID until either your own risk factors are reduced, like say it's longer after your last treatment, or until one or more of those types of COVID treatments becomes available in this country. Probably not necessary for the majority of us, but for some of you, this is a factor. So to summarize, before I sort of come to the questions, so Omicron is here. It will spread and it will do so very rapidly based on the experience overseas. Most of us will be exposed to it in the next 6 months. The good news is that Omicron does appear to be less severe than Delta. I haven't seen hematology specific reports of that, but we can expect it to be less severe. That doesn't mean that it's mild for everybody. Some people will still get very sick with it, but there's a lower chance of that. It is unfortunately very, very transmissible. Actions you can take, I strongly recommend you take up all available vaccine doses, even if your vaccine response is diminished because of treatments you're on. Some response is better than none, and I would still recommend going ahead and getting all vaccine doses that you're eligible for. And if they shorten that interval to the booster dose, then so be it. Go ahead and take it up as soon as you can. If you're in one of those very high risk groups that I outlined earlier, I'd seriously consider using a certified respirator when you're in shared indoor environments. I think that if you can get hold of those, I think that is warranted. Personally, I would do that. I would make sure I knew how to put that respirator on properly by watching some videos on YouTube or whatever. And I would, if I was in the shared indoor environments and couldn't avoid it, I would try and do what I can to ventilate those, open windows, open doors, maybe even if it was an appropriate situation, try and get hold of a HEPA filter, but they are expensive. And I would be seriously considering, if you're in those very high risk groups, if you're currently getting intensive AML therapy, if you are very severely neutropenic, if you've only recently had a bone marrow transplant, that you really need to look at what we call shielding. There's no formal government advice about that, but I would be seriously looking at limiting your social contacts, staying at home when you can. You don't need to worry too much about outdoor exercise. Aerosols don't tend to hang around for a long time outdoors, but those indoor situations, can you get your groceries delivered instead of going to the supermarket? I think for those very high risk groups, you might want to consider that. You can't do that your entire life, but we are in a situation where in 3 or 4 months, we may have some more COVID-19 treatments available. In 5 or 6 months, we may have some vaccines that are better tailored to the Omicron variant. So I think that's certainly something that you should consider. Many of us will get COVID, and if you do get symptoms that are consistent with it, and bear in mind that the Omicron variant can present like a cold, just a runny nose or sore throat, get yourself tested for COVID-19 and let any healthcare workers that you're speaking to, let them know of your blood cancer and of the treatment that you're on. So if you're speaking to Healthline and they're informing you of a positive result, say, I need to let you know I've got this condition and I'm on chemotherapy, or just say chemotherapy, it's not really chemo. They won't understand all the different drug names, because it's important that you do that, because it might influence the risk stratification that they use. So if they know that you're immune suppressed, they might recommend closer monitoring. So they might be giving you a home oxygen meter, or calling you or calling in on you more frequently. They might have a lower threshold for recommending an assessment in hospital to check your oxygen levels. And depending on what's available at the time, they may go on to recommend additional treatments to try and prevent severe COVID-19. So I do recommend that you let health practitioners dealing with symptoms know about your blood cancer and about its treatment. And that's really all I had to say. I can see that quite a few questions have come through on the Q&A, and I'll try and take those as much as I can. Yeah. I'll stop the screen share, sorry. All right, Jeanette asks, what do you mean by Pfizer being effective against Omicron? The Pfizer vaccine is still effective against Omicron, 15% effective. That's 15% reduction in infections with 2 doses, but 65% reduction in infection with 3 doses. That's the reduction compared to having no vaccine at all. So it's a much more modest vaccine effectiveness, but it is still effective. Both, even though it's 15%, that's still statistically significant. And bear in mind, this is the effectiveness against getting any symptoms from infection. The effectiveness against getting severely ill is a bit higher than that from both situations. Time frame about recently for risk factors for COVID. So for most treatments, it depends on what the chemotherapy or treatment is. So if you've had if you've had pure chemotherapy, so just cytotoxic chemotherapy agents, a lot of the impact on your immune system is over by about 3 months afterwards. But there are some treatments that affect your immune system for a lot longer than that. Examples of those, anything that contains rituximab or obinutuzumab, there the effect on your body's ability to make antibodies lasts at least a year. And if you've had drugs I mentioned like fludarabine, cladribine, bendamustine, there's probably still some effect on your immune system that takes a couple of years to improve. So the biggest risk is probably in the first 3 to 12 months after any treatment. The risk is probably much lower beyond 12 months. It's not a hard and fast rule. And to be honest, we can't even measure all these elements of immune system function in our routine labs anyway. So we can't give it's not like there's one time point at which the risk diminishes. So by the time you're 5 months after chemo, yes, the risk will be a lot lower than it was earlier on, or like during or in the first 3 months, but it probably, depending on the treatment, probably is still not back to normal. When you talk about types of blood cancer being at high risk of COVID-19, is that a higher risk of catching it or a high risk of having moderate or severe symptoms, or a combination of both? I'm mainly referring to a higher risk of having moderate or severe symptoms and requiring either hospitalization or intensive care. So that's what I'm referring to with the risk. The risk of catching it is more dependent on behavior and the prevailing risk in the community. And the behavior is something that you have the opportunity to modify. And catching it is a difficult thing because, of course, what happens is, especially once COVID becomes very prevalent in the community, we won't be able to test and confirm the disease in everybody who has it because the laboratories will be overwhelmed with testing capacity. So the reality is that there'll be some people who catch it but have no symptoms at all and never know that they've caught it. But yeah, I'm talking about severe outcomes, so moderate or severe, and hospitalization in particular. Is there any advantage in shortening the gap between the 3rd primary dose and the booster? So I don't know. I am not personally aware of a system for going ahead with the booster dose earlier. I guess one could try asking for it. I'm not aware of that. And really, I think the timing, that choice of 4 months to the booster, I think is a combination of wanting to get booster doses in sooner, but also the government taking vaccine supply into account and not wanting to run out of vaccine so there's none. So I think that's the moot point. I wouldn't be surprised if that 4 months got shortened to 3 months, depending on vaccine supply considerations. They could announce something different next week. I just don't know. So if you can reasonably bring it forward, that's fine. I'm not aware of currently a mechanism. We've not been advised by the Ministry of Health of a mechanism of bringing that booster dose forward. But if the government brings the booster dose timing down to 3 months, go ahead and get it when you can. Someone's asking if there'll be a copy of the talk available after the event. I think there is. It's been recorded, and I think a link to is going to be put on the LBC Facebook site. That's my understanding. Why did myeloproliferative patients not get included in the third dose criteria when they were in the UK and Australia? I don't know. I wasn't a part of writing those criteria. What I would say is early on, it was thought that essential thrombocythemia was a major risk factor for severe COVID. But in the second waves, and bear in mind the UK has now been on its 4th or 5th wave, that increased risk was no longer apparent. So it's just not in the criteria. I would say that the criteria are a compromise. There are infinite different permutations of risk factors, many that go way beyond people's blood cancer alone. And there's a whole raft of things that are included in those criteria. You can look them up online. There's a document available from as a link from the Ministry of Health website. It's like a 8-page document about those criteria. I would say that if you've got a myeloproliferative neoplasm and you're not on hydroxycarbamide, personally, I don't think that risk is enormous. Look, it may be similar to people with diabetes or other factors, and there was a desire to keep that third dose relatively constrained in this country. Got a question about risk of bone marrow transplantation, researching the gap or stand down period between the revaccination date. The government in this country has suggested revaccination from 3 months after bone marrow transplant. I think it's a reasonable time frame. You don't want to leave it too long because you want to get the benefits of vaccination as soon as you can. If you go too soon, the vaccine might be less effective. Personally, I think 3 months is a reasonable gap to start revaccinating, and I would feel comfortable with that. You could ask, particularly in the era of a lot of Omicron, about starting earlier. That in that particular case, that would be via your bone marrow transplant coordinator. A third dose and a booster. So I tried to show a chart showing the difference between a third dose and a booster. So the vaccine itself for any dose is always exactly the same at the moment. That might change, but at the moment it's the same vaccine. And effectively, there's a third primary dose and then there's a booster dose. So the one to get as the extra one is the third primary dose, then the booster is as normal. There's no difference in the actual constituent of the vaccine. It's exactly the same. Regarding masks, KN95 have ear straps, but you can purchase silicone straps to relieve the ears and go behind your head. Yeah, that's a good point. Yeah, that sounds reasonable. You can try and do that as long as it doesn't break the seal. I have to say, that's true that personally, I find the things with the behind the head strap a bit more comfortable for prolonged wearing. I don't like wearing these ones are given to us by the hospital, and they've got these and they're not very comfortable for wearing for a long time. But I mean, I'm not saying that ear strap masks are useless, just if you have the option, and you may not have the option, to try and get something with a head strap if you can. With stage 1 CLL on watch and wait, should I be getting a third dose before the booster? Yes, I would if you can. If you're eligible for a third dose, and you are, it does say CLL at any stage of treatment or CLL under monitoring. So it doesn't matter if that monitoring is by a doctor in hospital or by your GP. If you meet the criteria, I'd go ahead. Personally, I would go ahead and get the extra dose. Obviously, if you have a severe, really horrendous reaction to one of the vaccines, then that would need to be reconsidered. But personally, if I had early stage CLL and I was eligible for a third primary dose, I'd get that. And if you can do it, get that, and then you can still get the booster 4 months afterwards. Is a third dose available for under 12s ALL maintenance phase? Okay, I'm sorry, I don't know about that. I'm an adult hematologist. There's a relatively smaller number of children with blood cancers. In that situation, I'll be checking with your specialist nurse or your hematologist. Often there are special criteria that apply to children, and because I'm not involved in pediatric leukemia treatment, I couldn't say. So any questions about pediatric ALL and vaccination in children, I just suggest you please put those to your nurse specialist or your pediatric hematologist. I'm only really commenting on adult medicine because that's what I know best here. Sorry about that one. What should we do if we're in the high-risk group and we've got primary school age kids and partners? Yeah, this is really difficult, and there is no right answer to this. I mean, an analogous situation is if you're in a workplace and you haven't really got the option of working from home, which a lot of people will be in that situation. And I think it's one of the really difficult things, even though it's not explicitly been stated here, like it was in Australia. It's effectively a personal responsibility question, which is not at all helpful to you, and I appreciate that. But there is no formal government advice on that setting. So the Cancer Control Agency is going to try and put some specific recommendations around for cancer patients. We've highlighted to them the need for that to include very high-risk patients and what they can do. So I think you're going to have to be practical, and it will depend on the age of your children and on what can and can't be managed. So I would do what I can to hunker down, and in reality, if you've got family members who are out and about, that's going to be a real tough ask to do much. I mean, you know, is that hug dangerous? I don't know. You can't, I mean, no one can expect you to go and live in an isolated hut for the next 3 months, or maybe there's some people who can if you're wealthy enough, but it's just going to be taking practical measures to avoid it. You can perhaps those family members of yours, there is I believe children are being asked to wear face masks if they're in year 4 or higher, and depending on the child, some younger children may be able to try and wear a face mask while they're at school. Obviously, it's not going to be helpful for very young children where it's not at all feasible. And for partners of people who are at very high risk, partners may want to consider taking the same precautions as the patient, and consider also wearing a very good mask and trying to ventilate their workplace, and asking whether some elements of their work can be conducted from home. It is tough. There is no formal answer, because there is no formal shielding. And in fact, even in the UK, where they had shielding advice, they removed that in September last year because it just wasn't feasible to keep going. Are respirators available for children? I think they are, but they're much more difficult to get hold of. I would also say that, especially for younger children, they're probably more difficult to tolerate. I think they're a bit tighter, they're a bit hotter, because there's a little bit more resistance when you're breathing in and breathing out. So I probably wouldn't try and put one on a primary school age child. And with older children, they might be able to fit an adult one. And again, if you're talking specifically for children with blood cancers, I would actually be speaking with your own pediatric haematology service. A few questions more about that. If taking lenalidomide for myeloma and non-filgrastim, does that put me at high risk? That's a really good question. So lenalidomide is a moot point. So the first thing is that myeloma does appear to be a risk factor to some extent in its own right. A lot of people with myeloma will have had a number of different treatments, some of which, even if it's a year or two afterwards, may still be exerting some effect on the immune system. Lenalidomide on its own probably isn't too bad, even if you're getting a bit neutropenic and being on filgrastim. So lenalidomide is sort of more of an immune modulatory agent than an immune suppressant or chemotherapy. However, if the lenalidomide is being combined with drugs like bortezomib or dexamethasone, that probably puts you at higher risk. So if it's just lenalidomide and it's been, say, a year since the last transplant or more intensive type of chemotherapy, that risk may not be at the very highest end of the spectrum. None of the papers really tease this out because everybody's treatment journey differs. So I don't know. I'm on hydroxycarbamide. How will that affect COVID treatment? Well, the treatment that you get if you get COVID will probably at the moment be the same as for anybody else. For people on hydroxycarbamide, does appear to be a slightly lower antibody response to vaccination. So personally, I am suggesting those people get a third primary dose of the vaccine if they can. It's probably not an enormous risk factor, but it might be some. If you are taking hydroxycarbamide for ET or polycythemia vera, we would generally be advising that you continue any aspirin or blood thinners if you developed COVID, because COVID, if anything, increases the risk of blood clots. And we would generally be advising for most people, from at least with mild COVID, who probably would continue the hydroxycarbamide at the moment. If you got very unwell, it might be paused. There's one other thing. If you've got myelofibrosis and you're taking a drug called ruxolitinib, there is now strong advice that is not paused during COVID, because that seems to be linked to worse outcomes. That's a very small group, but that's just something that's come out from European data. Taking azacitidine, had infections after COVID-19 vaccination, reluctant to have third dose. It's difficult to know. I mean, the problem is if you've had an infection, is the infection related to the vaccine, or is it bad luck that the timing came along? Unfortunately, I think people with myelodysplasia on azacitidine are in actually one of the highest risk groups. I sort of ordered that list of high risk groups by those that were at the very highest risk, and right at the top was AML and MDS on treatment, and that included azacitidine. And this is from a fairly recent, quite large European study. So I would still be strongly advocating for as many COVID-19 vaccine doses as you can. If you feel deeply uncomfortable getting the Pfizer COVID vaccine again, you can ask to get the AstraZeneca one instead. It's still effective. It's not quite as effective. I don't think that would have a high or low risk of infection personally, but if you felt more comfortable trying the different one, you can do that. I personally, I would still try and push on and get a third primary dose and a booster if you can. What do you mean recent chemotherapy? I'm mostly talking about with someone asking who got treatment, last treatment early in November. Well, that's still within 3 months. I'd say that's definitely recent chemotherapy. I would consider yourself at high risk. The risk from that chemo will be beginning to wear off. But probably doesn't go down to nothing. So I'd still take precautions if you reasonably can. What does a transplant do to your immune memory? Well, transplant can eradicate your immune memory, which is why if you got COVID-19 vaccine and then you got a stem cell transplant, you are eligible for a full revaccination right from the first dose. How at risk is a child with ALL under maintenance? Again, I can't really speak to that, but I do think there is some risk. I mean, the drugs involved in ALL maintenance do suppress the immune system. But given that this is a relatively small group of people nationally, I'd be encouraging you just to, if you've got questions about what to do, just to check with your pediatric hematologist or nurse. So I've had a booster. This is an interesting question. I don't quite know the answer to this yet. I've had a booster dose. Will I need a fourth booster? So I think the first thing is that at the moment, most people are eligible for 2 initial doses in a booster. Many blood cancer patients available for 3 initial doses in a booster. So one thing is, will there be more doses? Almost certainly. Almost certainly, this isn't going to be an endemic virus. It's going to be with us forever, really. It's quite plausible that the annual vaccines tuned to the latest variants will be offered in the future. So I expect we'll all be offered some sort of additional dose in the future. And we'll be watching what the data on that is internationally. The other question is, if you've had 2 initial doses and you've got a booster without none of those under prescription, but you were in fact eligible for the 3rd primary dose, but you missed out on it, can you still go ahead and get that extra dose? You might be able to. If someone asked me in clinic, I probably would write a prescription for it and see it, but advise them that I'm not sure if it'll work out, and to see if it does. A lot of this, to be frank, has been a sort of criticism that the government's response to COVID was reactive. Well, frankly, I don't think you've got any choice but to be reactive in the face of a rapidly changing pandemic. And some of these nuances and details have not been formally worked out, and we just have to try and give our best advice at the time. And that's what I'm trying to do in this talk. How many times can the masks be used? Well, you're supposed to use them only once. 2 things about them. One of them is, if you use them too much, the straps might become loose or break, and then you lose the seal and they're pointless. So you certainly don't want to use them with inadequate straps. The second thing is they can get a bit yucky on the inside. Maybe that's more of a cosmetic thing. The third thing is, if you're in a heavily contaminated environment, in theory, the outside of the mask might have aerosols or droplets containing a virus attached to the outside. So in theory, if you look at those videos about how to take on and take off a mask, they often will advise you to wash your hands after you take it off, and to sort of take it off in one go. Again, watch those videos about how to do that. So you probably can get away with reusing them as they are expensive, and you may be loath to keep buying fresh ones all the time. But you do need to wash your hands carefully. You want to make sure that they're dry before you reuse them. They can lose their effectiveness if they're wet. I can't say exactly how effective, but I think you just have to be practical about that. I've mycosis fungoides, had tumors irradiated, manage it with diet and statins and vitamin D analogs. So interestingly, radiotherapy doesn't seem to be linked to a higher risk of COVID. So I don't think radiotherapy would be a risk factor, especially skin radiotherapy. So radiotherapy on its own probably isn't an enormous risk factor, and I wouldn't expect vitamin A analogs or statins to be a particular risk factor for severe COVID. The lymphoma itself might have some mild immune suppression effect, but if you've just had radiotherapy, that on its own shouldn't be a major risk factor. For people planning for an operation in early February, would you recommend postponing? That's a really interesting question. The stock advice, and I'd endorse this, is to continue to seek healthcare. And so one important thing, I haven't really emphasized this time, but I've spoken to this previously, it's still really important that you get yourself checked out if you've got bad symptoms. So there's no point trying to avoid COVID and Omicron and letting a relapsing lymphoma get out of control. It's better that you seek healthcare and get treated. A related thing is for those of you who are at very high risk of infection, say on AML therapy, if you get a fever, don't assume it's Omicron. It could be a neutropenic infection and you need to go in and get yourself checked out in case you need antibiotics. It's one of the reasons it's important to let Healthline know if you're speaking to them about an infection that you're on chemo and that you've got a blood cancer. Should I have an elective operation postponed? I don't know. It kind of depends what the operation is. I would say that hospitals are doing a lot to try and reduce the risk of picking up COVID in hospital. However, internationally, certainly there was a lot of spread within hospitals. I would say, for example, in our own hospital, there's been a lot of work on the ventilation system, so putting filters in to reduce that risk. So ceilings have been brought down, HEPA filters have been installed throughout the inpatient areas. So I think you have to look at what that operation is. If it was a cancer type surgery, definitely don't avoid it. That has to go ahead. If it's a purely elective operation, if it's cosmetic or if it's a joint replacement and you really don't mind, maybe you might decide to put it off. On the other hand, there's no guarantee that things will be any easier in 6 months' time. We could have a new variant then. So I just don't know for sure. If I've got rheumatoid disease and heart failure, and a history of non-Hodgkin lymphoma. So I've only been talking about blood cancers, but it's clear that there are some people whose immune system is weakened by other conditions, and some of the treatments for arthritis are similar to the treatments used for lymphoma. So rituximab is used for arthritis as well as for lymphoma, and that certainly increases risk of COVID. If a treatment was, if the last treatment for lymphoma was more than a year ago, and the lymphoma is in remission, it's probably not that's the major factor now, but there may be some increase in risk just from the fact of having arthritis and just from the fact of any other illnesses. And I can't really speak to those, they're a bit outside my area. How much risk when meeting people outdoors? Much lower is the answer. So when you're outdoors, those aerosols disperse much, much better. And the risk is a lot lower. It's not to say it's zero, but it's certainly a lot lower. And if you can meet outdoors, then do. And for many people, it's probably, there's benefits to meeting people and having physical exertion. So if you can have spaced meetings outdoors instead of meeting indoors, that's probably a lot better. If a person has very low IgG because of Waldenström's and that's likely to stay low, would they likely have a worse outcome? Possibly is the answer, because if you've got low IgG, you probably don't make a good vaccine response to the vaccines, and that probably is linked to a risk of worse outcomes. However, even if you make no antibodies in response to the vaccines, you can still get so-called T-cell responses, which can be protective. And so if you've got Waldenström's, you're eligible for 4 primary vaccine doses. Go ahead and get 4 initial vaccine doses plus a booster. Go ahead and get them all. And if you are currently on treatment for Waldenström's, you've recently had chemo for it, I would also consider doing the things I was talking about with face masks and possibly shielding. I asked for an early, someone saying I asked for an early 4-month booster. They said no. Yeah, look, that's my understanding. It's difficult to get around these national rule sets, and I don't know evidence to say that it's better to do so earlier. We just follow what the government advice is. They may, if supply becomes available, they may bring forward the 4-month for everybody anyway. And what do you live? You've got a under 5-year-old who attends daycare and you're less than 12 months post-autograph. Well, the first autograph, the first 3 months are probably the most highest risk. The risk does drop after that, and hopefully whatever you were treated for is currently in remission. I would say I would just be getting all the vaccine doses that you can. And again, it kind of depends on how you feel and how important the childcare is and how many hours per day. But if I had a young child, you're also going to consider their development and their well-being. If they've been going through you having an illness as well, and they might just have to go to childcare. And if they do develop symptoms, then you might see if you can try and stay away from them, at least for a period. So I think I'd be most worried about the first 3 months. There's no hard and fast rule to this. If you test positive for COVID as a blood cancer patient, what additional steps to the standard health advice? So the main thing, there isn't really much different you can do, but the main thing I would say is to get yourself tested and to let any healthcare workers in. And bear in mind that a lot of your healthcare, if we get very busy, which is likely to happen, might be delivered by doctors who don't know you. So you might be dealing with Healthline over the phone. You might be dealing with GPs or nurses who don't know your medical background. Make sure they know about your leukemia or your lymphoma and the treatment that you're on, and that you're immune suppressed. The specific question here is about Sprycel, which is called dasatinib, and it can cause fluid buildup on the lungs. Should you stop taking it? Generally, no. I think the current advice is that for TKIs, tyrosine kinase inhibitors for chronic myeloid leukemia, they don't seem to increase the risk, and I would probably be continuing it unless there was clear evidence of fluid in the lung. So for that, in that case, I would continue. Ruxolitinib, I would continue. Certain chemotherapies that are non-urgent, we might pause if somebody got bad COVID. Now, if you did get COVID and you end up in hospital, you probably won't be treated by your haematology team. You'll probably be treated by a COVID treating team, and that's to try and keep COVID patients off the haematology wards. But they will be able to speak to your COVID team, your haematology team, and get advice. In risk of AML, is that inclusive of APML? Well, acute promyelocytic leukemia is a special condition where it's often now treated with chemotherapy-free regimens. The risk is, I would say the risk of severe COVID is probably lower in acute promyelocytic leukemia if you're not getting chemo for it, if you're getting ATRA and arsenic. However, I'm not aware of any specific data on that. So it probably is lower for APML if you're getting the non-chemo options. I'm probably going to leave it there. I've had quite a few questions. There's a few more clearly on there. I hope it's been helpful. We've run a bit over time. I believe this is going to go on the LBC, a link to this will go on the LBC Facebook page. And look, I know there's a ton of questions. I can't alleviate every concern, and none of us have got clear answers. But take care out there. Do be reassured that this does appear to be a milder variant. The current projections that the government are working on looks hopeful that we won't have overwhelmed healthcare services. We have had the opportunity to get vaccinated, and the vaccines do have some effectiveness. We do have a number of COVID treatments, and there likely are more coming. If you're in a high-risk group, I would see if you can reasonably do so, then I'd try and shield yourself as best as you possibly can.
Thanks, Rob. It's very kind of you to come back for yet another COVID talk, and it's much appreciated. And like Rob has alluded to, this talk will be posted on our YouTube channel, so keep your eye out for email notifications and on our Facebook pages. Thank you.
Thanks all. Have a safe time.
Bye.
Bye.